If you're ready to unlock more better days, to take control of your health, to push past your limits and unleash your full potential, then you're in the right place. I'm your host, Dr. Jeremy Bettel. For over 2 decades, I've worked with elite athletes and high performers, helping them optimize their bodies, strengthen their minds, and recover from setbacks. Now I'm bringing that expertise to you through the Vitality Collective podcast. In each episode, we'll dive deep into the science, strategies, and real-world solutions you can apply right away. Whether it's enhancing your physical performance, avoiding or recovering from injury, sharpening your mental edge, or simply feeling your best every single day. With insights from top experts and thought leaders, this podcast is designed to help you take action, feel better, and live the life that you deserve. Welcome to the Vitality Collective podcast, where every day is vital. Today I'm joined once again by Dr. Dennis Hughes, a board-certified internist specializing in longevity and proactive healthcare. In this episode, we talk about what a truly comprehensive blood panel looks like, covering why most routine labs fall short, how to catch insulin resistance and cardiovascular risk before symptoms appear, and why your blood work is one of the most powerful tools that you have for protecting your brain, your energy, and your long-term independence. If you have ever left a doctor's appointment feeling like you got a clean bill of health, but something still felt off, this conversation's for you. Let's get into it. It is such a pleasure to welcome back Dr. Dennis Hughes. Now, Dennis was one of the first guests. You were like maybe number 3 on the show, I think, maybe 5. So it's great to have you back here up into the 60s, into year 2.
Wow.
So thrilled to have you back, Dennis.
Nice to be here.
So, mate, we're going to dive into blood work today. I think a really important and somewhat underrated area of our health monitoring. One of the reasons that this is important to me, just as a part of our high-performance health model, we like to use metrics to look at trends in the directionality of where your health's going. We use this methodology for preventing physical injuries in hockey and other sports, where we would measure and monitor risk factors. And if people were heading in the wrong direction, we could course correct and bring them back into a safe zone. And as we zoom out into wider health, I think it's really important to understand that what's going on in our internal landscape is directly correlated to the direction that our health is going, and really related to much of our lifestyle and how we're taking care of ourselves. So I'd love to hear a little bit more about the typical blood panels that get ordered that maybe are sort of minimal labs that get done on your routine check, and why you tend to dig a little bit deeper, as you did with Michelle and I recently.
So I look at the blood panels ordered by other practitioners, and I often see really basic, kind of older fashioned panels. For example, I see blood cells being ordered without iron being ordered up front. I see evaluation for kidney function done in which only creatinine is being used and not cystatin C, which might be more accurate and not influenced by supplements such as creatine. I see incomplete lipid analysis panels and so on. So I don't want to order tests just to order tests. I want to order tests whereby I can have some actionable step if needed, if I see something that's not optimal.
Yeah, and I think that's the really important thing is the deliberate nature of how you approach the design of the blood panel. You know, it's not just the standard off-the-shelf panel as we've seen and went through. For me, this is really a way that we can go about early detection versus being really reactive down the line if we're really deliberate. One of the things that stood out in our recent conversation about my blood panel was actually before I went and got my blood drawn. And I've heard you say this with a couple of people that we've worked together with. You wanted my eyeballs floating, right? You wanted me to be hydrated. And so there was actually a lot of conversation around the preparation for me going to get my blood drawn. I've never had a doctor describe that to me before or give me any prep work to do before I got my bloods done. Walk us through what your process is before that and why that's so important.
Well, first of all, it's surprising to me that it's pretty standard. So hydration is an important aspect of preparing for the lab draw. Older people in particular lose their thirst mechanism. They will tell me sometimes, I just don't have enough water. I know I don't.
Mm-hmm.
And, if you go to your lab draw and you're underhydrated, your lab results can be skewed. For example, so during the night, we're evaporating sweat, we're breathing out water vapor, we're clearly not taking water, and you're slowly dehydrating throughout the night. That's why your urine is dark in the morning when you first get out of bed. That can cause artifactual results whereby, for example, I might think you have a kidney problem.
Mm-hmm.
Or maybe let's just assume that you're anemic. But if your blood is concentrated because you're underhydrated, I may not see that anemia. Your blood
Right.
cells may look artifactually elevated.
Mm-hmm.
We've seen this many times in the emergency room where someone has gastroenteritis and they're dehydrated. And the first blood test they pull shows a normal complete blood count. And then we give them an IV bag to rehydrate and the hemoglobin goes down. They're anemic. Wouldn't have seen that had I not hydrated. And so I asked people to start hydrating the day before, and especially the morning of before your blood is taken. People ask me, how much water should I have? I say enough to where your urine's clear. I want Niagara Falls.
Right.
And,
Right.
and there are other things that you should do to prepare yourself. If you're taking biotin containing supplements, biotin can interfere with the assay for thyroid panels, electrolytes, and others. So I tell people not to take any of those biotin containing supplements for a week before.
Oh, a full week.
Mm-hmm.
Yeah.
Maybe that's just a little extreme, but I just want to make sure that there's nothing botching up the results and throwing me off the scent.
Yeah.
Also, I think people assume they shouldn't take their medications or supplements on the day of a blood draw. I tell them go ahead because I want you to take your medicine as you need it. And it's not likely to throw me off when I'm interpreting your testing.
Mm-hmm.
I saw a YouTube episode from a young doctor who was giving similar advice. He did a really good job. In it, he advised not to have any caffeinated beverages before the blood draw. And I could kind of see where he was going with that. He didn't want the cortisol to be up because you were having 3 cups of coffee before the draw. I don't advise that. Most people really want their coffee or tea before. And aside from maybe cortisol, I can't really see how it's going to affect the lab results so much. When you ask people not to have their coffee before the blood draw, you see their eyes dilating.
Yeah.
What?
Yeah.
So I just tell them to go ahead.
Yeah. And what about fasting? Often with the athletes, we would do non-fasted when we're just doing little checkups. Is there a reason to be fasted versus non-fasted?
Yes. So I can compare apples to apples. Let's say, for example, last year you had a fasting blood draw, but this time you didn't. So after a meal, your blood glucose is going to rise. Your triglycerides, also known as blood fats, will rise. So maybe last year your triglycerides were lower and they look higher this year because you ate something or drank something before you got your blood drawn. And how can I compare them side by side? That's the real reason to not eat before. Now, there are some times when I don't need a fasted sample. If I'm evaluating someone's electrolytes or blood cells, provided that they've hydrated, I don't need them to fast for that.
That makes a ton of sense. And I think that really highlights the point that the really good labs depend on good preparation.
Consistency in preparation.
Yeah, and exactly, so that we can compare this longitudinally. And it goes with so many of the tests that we run, whether it's body composition or anything else. Having the same preparation gives us that opportunity to compare sets of results. So I really think that's such an important point for people to understand here.
Also, I ask people, especially if they're a new patient, to bring in their old labs if I don't have them already by snooping in the computer. Because, folks like to look at guidelines for what's normal, what's a normal range for their testing. Well, let's say, for example, for a man, a hemoglobin is somewhere in the 14s to 16s. And I do a blood panel on you and yours is 14.5. I might say, okay, that looks kind of okay.
Yeah.
But what if it was
Yeah.
16 last year? Something's changed.
Yeah. Yeah. And that's such important context, isn't it?
It is. It's one of the
I
most
always looked
important.
at that. Yeah. Yeah. Like an individual's baseline. It was the same with injuries. We didn't necessarily mind if you were super tight but symmetrical. It was if you were really flexible and became really tight or became really asymmetrical.
Mhm.
So long as you were within your average range, we were pretty comfortable with it. But it was the big changes that we didn't like to see,
Sure.
because then something had changed within you, as you described, where we knew there had to be an adjustment to get you back to your range
Mhm.
so that we could be more comfortable with you performing safely. And I think that's the same here. You know, we need to look at these trends over time to see if you're heading in the wrong direction at any point. And so one of the things, Dennis, that I'm interested here is we see this a lot in men's health, but I think it's pretty universal, where you go to the doctor every year and they tell you, you know, this is high, that's low, you've got to eat better, you've got to exercise. And then you completely ignore them and you come back the next year, it's the same message. And so why should people be coming and getting their labs and really paying attention to the feedback that they're receiving here? What are the labs telling us?
The labs will show us problems that maybe haven't blown up on you yet. Maybe you don't have any symptoms at this point. Many disease processes that cause ill health have been brewing for decades before they show themselves, like coronary
Right.
artery disease or
Right.
dementia. If you show signs of Alzheimer's dementia at 75, that's been brewing for decades.
Yeah.
And I kind of understand why some patients don't take action on these abnormal results, because they don't feel anything yet.
Mm-hmm.
These are
Yeah.
silent abnormalities.
Yeah.
So there's a disconnect there. I do my best. I try and tell them that they should take good care of themselves, but that's all I can do, is
Yeah,
paint a
it
picture
is.
of what may happen should they not heed the warnings that I'm seeing in the laboratory results.
Yeah. I remember on one of our hikes there in Santa Barbara, you and I had this conversation, and I think it is the silent nature of how these states progress that makes them so dangerous, but also makes this so important, because it's not how you feel today, it's how you will feel if these numbers stay where they are or worsen.
Right. I think I gave you this example at one point in the past when we were walking and talking. I was showing this guy his lab report, and I said, look, you have insulin resistance and prediabetes, and this can cause a whole host of problems, including coronary artery disease, type 2 diabetes, dementia. And he said, Doc, my numbers have been like this for 10 years. And I told him, that's the problem. Your numbers have been like this for 10 years.
Yeah. Yeah, that's exactly it. And these are cumulative and compounding effects. And so let's talk about some of these links. You mentioned a couple of there, like cardiovascular disease and dementia developing. What are you looking at there? What's giving you that indication that we might be progressing along the wrong path here?
So when I look at a laboratory panel, I triangulate. I try to look at each system with multiple different tests, because
Right.
you can have one abnormal test in isolation. That doesn't necessarily mean you have a big problem with that system. You know, these guidelines for reference ranges, what's normal,
Mm-hmm.
they're just a rough guideline. They're a rule of thumb. Human beings are not machines, you know, and some of our numbers are going to be a little off. That doesn't necessarily mean you have a disease process. For example, I think most laboratories, when we're looking at a complete blood count, set the bar of expectation for a white blood cell count way too high. So many people have a white blood cell count that's flagged low. And, you know, the good thing about me having white hair is I've seen people for 15
Yeah.
years in a row, and maybe they have a white blood cell count that's 3.2, 3.4. It may bounce up and down a little bit, but that person didn't have any more infections than the average person over the course of every year.
Right.
They had a healthy immune system, presumably. So to start, one important system is your glucose metabolism. So the typical studies I would do is a fasting blood glucose, an insulin level, I look at your triglycerides and I look at your VLDL cholesterol and hemoglobin A1C percent. One of the things I use to calculate the possibility of insulin resistance is something called a HOMA-IR score. That is your insulin level times your fasting blood glucose divided by 405. And a
Right.
HOMA-IR score below 1 would suggest no insulin resistance. Somewhere between 1 and 1.9 is some, and 2.0 and above is for sure insulin resistance and take action.
It's such an important thing because insulin isn't on the typical panel. We'll see blood glucose, we'll see a hemoglobin A1C, and they can sort of be flagged as normal, but can give us a bit of a false indication, can't they, if we don't also have the context of insulin?
So insulin to me is like the canary in the coal mine of stress in your glucose metabolism.
Yeah.
If the insulin level is elevated, it would suggest that your pancreas, which monitors your blood glucose level and secretes insulin and other hormones, is under stress and is trying to compensate for insulin resistance by producing and secreting more insulin. So we talked about this before. I have 3 buckets for lab reports. I have bad, okay, and optimal. So my optimal insulin level is below 6 in a fasted state. Glucose level is tricky because you might have a so-called elevated glucose level with your morning blood draw, but you should know that your cortisol level rises at 6 or 7 in the morning, and that may drive up the glucose level. Also, you haven't been up and around presumably so much so that your muscles haven't soaked up some of that glucose from your blood. And, if someone has a slightly elevated fasted glucose, maybe if you took that glucose 2 hours later, after they've been up and around and they haven't had anything to eat yet, it might dip back down. So that's the situation where I have to look at all the other parameters to wrap my head around this and see if there is an issue or not. Because historically, I have seen some people with a slightly elevated fasted glucose where they didn't have any other sign of insulin resistance or metabolic stress.
Yeah, that's interesting because I've seen that in my own blood work. When I've monitored blood glucose, I've seen my fasting glucose be a little elevated, but actually my A1C and my insulin are fine. So I hadn't necessarily put that together with the rising cortisol and the fact that I just hadn't been up and about yet. I think that's a really interesting perspective.
And, the laboratory reference range will show you that a hemoglobin A1C percent of less than 5.7 is technically normal, although that's not my target. I try to aim for an A1C of 5.1, which corresponds to an average blood glucose of 100. And of course, that's, the hemoglobin A1C percent, for those folks that don't know, is an average blood glucose over 3 to 4 months. And that includes a hodgepodge of fasted and non-fasting states.
Yeah. And that's, let's dig into that a little bit. The hemoglobin A1C, that's how we classify conditions like prediabetes and diabetes, right? So can you give us some numbers around where we start to drift into those disease states?
Well, it's interesting you ask. So you can diagnose type 2 diabetes by a hemoglobin A1C percent of 6.5 or more, or a fasting blood glucose of 126 or more, or both. And a while back, I inquired why a fasting blood glucose of 126 and more is type 2 diabetes. That seems kind of arbitrary. Apparently, diabetic retinopathy, retinal disease, was first observed with a glucose of 126 and more. So they arbitrarily, that's diabetes.
Right.
We have to draw the line somewhere, and that's just where they chose to draw it.
Yeah.
But it's a continuum.
Yeah. Where do we start with prediabetes? Where's the classification for that?
So prediabetes would be a hemoglobin A1C percent of 5.7 to 6.4, fasted blood glucose of 100 to 125. But again, it's a continuum. If a person has a blood glucose that's less than 100 in the fasted state, yet they have an elevated insulin level, maybe, and these are just my guidelines. Maybe some people would disagree, but for me, a triglyceride level above 100 is abnormal and suggests insulin resistance. The laboratory guidelines will say less than 150 is normal, but I disagree and lipidologists disagree as well.
Yeah. Yeah.
The lab guidelines will often say that a VLDL cholesterol less than 30 is normal. And I would say for me, less than 15 is optimal. In the insulin resistant state, the VLDL cholesterol and triglycerides will both rise.
Yeah. And that's, you mentioned something really important earlier as well about the spectrum here. Like that this is a sliding scale with we'll use the A1C. And I use this a lot with my clients when we're talking about this. This is where that normal range, if you just take this year's normal, can be quite deceptive. Because if over 5+ years, you go from a 5.1 to a 5.2, 3, 4, 5, 6, you're normal and fine in every one of those according to that individual classification. But the next year you show up and surprise, you got diabetes, right? When there is something you could have been doing about it. There is action you could be taking. When you see those first, say, 3 data points all going in the wrong direction, and you've then clustered insulin and these other factors around them, I think it's really important from our early detection standpoint to start noticing trends even within that normal range.
Yeah, for sure. You know, I always tell people, I don't bring you in here and do labs to scare you. I just want to identify these silent issues that are brewing so that you can take action and turn it around. Insulin resistance stresses the pancreas. The pancreas has to work harder to maintain a normal or near normal blood glucose in the setting of insulin resistance.
Yeah.
You may not feel it, but your pancreas is burning out. You're losing those little insulin producing cells.
Yeah. Well, and not to mention, because we hear diabetes, we hear insulin resistance, but without an awful lot of understanding of what that means. And so can you help us understand in a literal sense what happens in the body when you start becoming insulin resistant?
After a meal, your pancreas, which senses your blood glucose level, senses the rise after a meal, produces insulin. And think of insulin in basic terms as a key that unlocks the door of the cell membrane and lets the glucose in through a transporter. So when glucose rises and insulin is produced and interacts with the receptor on the cell membrane, there's a waterfall of chemical reactions that happen. There are these glucose transporters, which are inside the cell, which after this cascade of chemical reactions is initiated, this collection of glucose transporters goes to the surface of the cell. The door is open and the glucose comes in. Within insulin resistance, that cascade of chemical reactions is blunted. And so those glucose transporters are not able to go to the surface of the cell membrane and let the glucose in. So that's insulin resistance.
Yeah. So for the same amount of insulin that we release, we're actually not able to take glucose into the cell. So that's why our blood sugar starts rising, correct?
Yes.
Yeah. And I think what we need to frame here as well is glucose in the body is the fuel source. And so for the muscles to function appropriately, glucose has to come into the cell and be converted into energy in order that we can function and exercise and do all our activities of daily living. But it's not just the muscle cells, it's also the brain cells. And so our brain cells our neurons will become insulin resistant. And so now we have a harder time taking glucose into the brain. And I think that's where we start seeing problems in some of these instances, is where we start depriving really important areas of the body of energy, essentially.
Yes. So tissues that are the hungriest are vulnerable to degeneration when there is a supply-demand mismatch. Your brain burns 20% of your sugar every day, and it's pretty hungry. And if it doesn't get what it needs, actually, it's the astrocytes, which are the supporting cells next to the brain cells, that take up the glucose and turn it into lactate. And the brain cells feed on the lactate.
Mm-hmm, mm-hmm.
But insulin resistance causes a whole host of other problems. The fat molecules are not burned. And also the liver, which usually is shut down from producing sugar when insulin is present and functioning. If there's insulin resistance, the liver will continue to make sugar molecules in a process called gluconeogenesis, and it will pump that glucose out into the blood without any regulation.
Right. Right. Because it's sort of responding to the lack of energy that it's receiving and thinking it's got to keep creating more and more sugar.
Yes.
So it's a really vicious cycle there. And along with that, then we start looking at things like inflammatory conditions, which start to cause a whole other cascade of events. How does the inflammation start to build as a result of this?
Well, most insulin-resistant patients have visceral adiposity, which is increased obesity. This is the fat that surrounds and encases your organs. And that adipose tissue secretes signaling molecules called adipokines. And some of those are inflammatory, like interleukin-1, interleukin-6, tumor necrosis factor alpha. And so they can cause widespread inflammation in the body. As a matter of fact, if I have a very obese patient and I did inflammatory markers like CRP and sedimentation rate, you may see that they're mildly elevated.
Yeah. Yeah. And I think what's important as we start following this train of the cascade of events, when we're talking about blood glucose and how we can impact it, there should be a normal rise and fall, right? Let's not, I don't want anyone to take here and start getting carb phobic, like we shouldn't see fluctuations in blood sugar. But what we can also do, like exercise, even really short exercise snacks, as we call them now, of 3 to 5 minutes, we're really seeing has a profound impact on blood glucose levels. Things like taking a walk after meals, in between meetings, I'll go next door, I've got my dumbbells, and I'll hit some, like a quick circuit, 3 to 5 minutes and come back in. Great for focus, great for bringing blood sugar down, because there are these mechanisms to take glucose into the cell that happen during exercise that are actually independent of the insulin. So we don't want to paint a picture that this is a slippery slope when you're done with. There's so much we can do about it that we'll get into a bit more detail down the line here.
Exercise snack. I'm going to steal that one.
You're welcome to it. I didn't make it up.
No, you're right. Exercise does allow the cell to put more glucose channels in the cell membrane.
And so I think as we carry on here, we started talking about inflammation and the standard high sensitivity reactive protein that we would measure. We had an interesting conversation around that. You again use a cluster of tests around inflammation. What would you be looking for in a blood panel? Because it's become a bit of a boogeyman, inflammation, and a bit of a buzzword where everything is, oh, we're inflamed and with this and with that. Well, how do we know, right? Like we can measure this stuff. You don't have to just go and take every supplement on the market because people are scaring you and telling you you're inflamed.
I typically don't, as a routine for a physical, do inflammatory markers because they don't really tell us what specific condition is going on. Right. Yes, it shows us there's some inflammation, but I worry that it causes more concern on the patient's side. Maybe they're going to start worrying that they have a lurking, really ominous process, but I can't tell from the inflammatory marker because it's kind of a vague result. What am I going to do with that result? I'm not certain. Aside from if they were obese and I coach them to lose weight, eat better, exercise more, and some people take medication and track those inflammatory markers, you would probably see them drop.
Yeah.
But I don't do it as a routine.
And so what are you paying attention to? Is there something instead that you pay attention to, or is it more into these other clusters of tests that you're doing?
Well, neuroinflammation is thought to be a strong cause of Alzheimer's dementia. And in people that want me to look into this, or if I feel that they're high risk and I really want to provide some feedback to my patients so they can get a kick in the pants and start taking better care of themselves, I might order p-tau and amyloid beta 42/40 ratio testing. These are molecules which in the past we could only detect by doing a lumbar puncture, a spinal tap, but now we can just as accurately do them with a blood test.
Yeah, and again, I think the inflammation piece, it's interesting because my role in guiding people through the exercise process, I'm acutely spiking inflammation with basically everything that we do. We break down muscle. As we lift weights, we do a lot of high intensity work. We see a spike in inflammation that's short term, it's acute, and has a very positive effect on the body.
There's a healing process.
Because there's a healing process that upgrades that tissue, right? So again, it's these natural ebbs and flows, and we can villainize inflammation and think it's always bad. And that's another thing that we saw with the athletes is we had to be really careful measuring inflammatory markers because they were practicing every day, right? So you come in after high intensity exercise, you can see an increase in inflammation.
That's a really good point, which I rarely hear spoken.
Mm-hmm.
Inflammation is not a 100% bad thing.
Yeah.
It's a necessary thing.
Right. I think the difference there is when it becomes chronic in situations like insulin resistance and obesity. It's the chronic nature of inflammation where we don't get that natural ebb and flow and rise and fall that really becomes problematic for us.
For sure. And insulin resistance changes the distribution of the cholesterol-carrying particles called lipoproteins. LDL, for example, is a lipoprotein. And modern living, which promotes insulin resistance, has changed the distribution of these cholesterol-carrying particles such that they more easily end up in the artery lining to cause inflammation of the artery wall.
Right.
I think many people consider, artery disease as just a blob of cholesterol sitting in the lining. It's not that simple. It is a chronic inflammatory destructive process in the artery wall.
Interesting. So let's start digging into that a little bit then, because again, like not only do I see markers like A1C and diabetes as sort of progressive and on a sliding scale, but I sort of see the chronic diseases on a similar scale where we start with some insulin resistance and metabolic disease, we progress into diabetes and we get more inflammation along the way. And then maybe we start progressing into the cardiovascular diseases where our blood lipid panel becomes really important. What are the lipid panels that you look at? You mentioned the profile changing, but what specifically are we looking at here?
So we look at triglycerides, which are blood fats, and I aim for less than 100. I read a lipidology book once that was describing that some hunter-gatherer societies allow their blood to be tested. And you're seeing triglyceride levels of 30s.
Wow.
And, that's what happens when you don't eat processed food and an overabundance of food.
And too much of it.
Now, typically when triglycerides are low, this is not a hard and fast rule, HDL cholesterol is high. These two go in different directions. So therefore, in my insulin-resistant patients, I often see a low HDL cholesterol. Some people have a genetic basis for low HDL cholesterol, but the majority of people in this country with low HDL have insulin resistance. I look at LDL cholesterol, and just to be specific, because as you know, doctors have dumbed this down for people over time and said LDL cholesterol is the bad cholesterol, HDL cholesterol is the good cholesterol. So that is a poor way to explain it, in my opinion. When we look at LDL cholesterol, specifically what that result means is that in a deciliter of blood, 100 milliliters, you have, let's say your LDL cholesterol was 100. So in all the quadrillion microscopic LDL carriers called lipoproteins, you have 100 milligrams of cholesterol packed into those LDL carriers as a whole. So, LDL cholesterol can be elevated in people who take a lot of saturated fat, but it can also be elevated because of genetics. I also look at apolipoprotein B, which for my money is the most important metric to look at. Every LDL lipoprotein carrier has exactly one ApoB molecule. So what we're doing when we're measuring ApoB is indirecting indirectly counting the number of LDL lipoprotein carriers. All of the lipidologists that I follow believe that this is the most important test because insulin resistance tends to make the LDL particle smaller and denser and more numerous. That's the change in distribution. Instead of the LDL lipoprotein carriers being big, they become dense and small and numerous. This is an inexpensive test that's easy to do. All labs do it. And I can't see why people are not ordering it. It's a real miss.
People listening need to understand that they can request. And often a response that I've heard is that they'll just be told, well, that's not covered by your insurance. And they just take that as, oh, okay, then we won't do it because you assume it's going to be some big expensive test where actually it might cost you $3, right? Or it might actually be covered. And so I think that it's a really important one to advocate for yourself for with your physician. Like, hey, can we add this to our blood panel?
I'll tell you, I've never had one patient ever call me or email me and say, oh, that ApoB test was so expensive. Why did you order it? Not one. That tells me it's not expensive.
Yeah. So I think that's a really important point there, just to make sure that people are thinking about that. The particles becoming more numerous, I think, is a really important point as well, with the pressure gradient that creates for cholesterol within the blood vessel, where we actually start seeing more and more of those particles, and they actually, because they're so small, becomes very easy for them to go into the lining of the blood vessels.
Well, more numerous. That's like an equilibrium.
Yeah.
We often see this in insulin-resistant patients. I don't want to bore you with all the details. People are going to fall asleep, but this can be reversed, actually. Should you take the right steps, lose weight if you're overweight, exercise, eat the proper food, a Mediterranean diet, low refined foods, your ApoB can go down. Now, if you have established coronary artery disease, our target for ApoB is going to be really low because we want to arrest the process. Because there's a dynamic, right? LDL cholesterol, VLDL cholesterol, and lipoprotein little a are crashing into your artery wall and dumping off cholesterol and other things like oxidized phospholipids. And the HDL carrier can drift in the artery wall, remove some cholesterol, and drift back out. We want the net dynamic to be that you're removing more than you're placing into the wall.
Yeah. Mm-hmm. It's really interesting when you're with the teams, you've got this really closed environment. And it's like a really interesting social experiment because you put all of these people into a super stressful environment. And the NHL, its nickname is the Never Hungry League. And so we've got food everywhere all the time that is for the athletes to fuel NHL hockey, right? We're fueling them for practice. We're fueling them for recovery. We're fueling them for games. But the staff also have access to all of that. So you can't turn around without like a really high calorie food somewhere. And so we also measure everything with both the staff and the players. And when we come in from the summer for training camp, everybody's in great shape. All the staff have got great blood work. It's fine. And as we measure that through the season, we see triglycerides, we see lipid profiles shifting all the way through the season until the end of the season. You would have a heart attack yourself if you saw some of the coaches' blood works. And then they go away and they have to cook their own food for a summer. And you see it drift back. They're exercising, the stress drops. They're really taking action almost passively because they're not surrounded by food all the time. But you see such a shift as the calorie intake drops, the density of the food, the frequency of the food that they're eating decreases. And it's amazing the shift you see back to when we come back in the next year. Everyone's back to a baseline within a standard deviation.
It's hard to blame people for overeating. Eating is a survival instinct. You put food in front of people, they want to eat it.
Well, and especially when it's that we get into the psychology of eating, that when it's abundant and surrounding you, if every time you walk past a table, there's a buffet with, and by the way, we hired like gourmet chefs, built a kitchen. Like, this is good food. And we know that when you eat at a buffet, you eat about 25% more calories than you would if you were just cooking your food. right? Because there's several options. What if all the players don't like fish? So we've also got chicken, and maybe we've got a beef option. And so everybody's going down and grabbing a bit of all of it. But as
Yeah.
step, burning the calories off like the players are.
Yeah, they're not burning 4,000 calories a day.
Right. And so it's very interesting. But to your point of you can do something about this, I think it's really important to understand that, and it was a big wake up for me one year when I saw my own blood work drifting of like, wow, I'm just taking in too many calories. And so immediately made an adjustment myself, and you just see everything start to come pretty quickly back into line.
Yeah, same thing happened to me. I had prided myself on keeping a flat belly. My triglycerides were in the 40s. And then, I started eating bread and maybe having a beer or two. And my triglycerides went up to like 90s. And I'd not seen that in a long time. So that kind of lit a fire under me.
Yeah, it really does. And I think, one of the terms that we use is awareness regulates, right? And I think that's the importance of doing this testing and gathering this data and understanding your internal landscape, is that it's easy to ignore it because you don't feel it if you don't measure it. But when you start regularly tracking, I think it guides a lot of your decision making and helps you really intervene intelligently and with precision. And just knowing you're going back in 3 months, like my doctor's going to look at this again.
Right? Put the guilt on me.
Yeah, exactly.
Yeah, I'm pretty sure if insulin resistance caused itching or something, people would be on it, I gained 5 pounds. I'm starting to scratch.
Exactly. And so I'd like to touch outside of blood work real quick here as we talk about plaques building up in the cardiovascular system. Some of the measures that can be done to actually monitor the outcomes here. So if you've got elevated cholesterol and you want to know if that's having an impact, things like coronary calcium scores, like ultrasounds of the carotid artery, do you often recommend those to your patients?
I've been ordering coronary artery calcium scans for over 20 years, but there are pros and cons.
Yeah.
The pros for the calcium score are it's cheap. It's about $150 to $200. If there's calcified plaque, you'll see that, and it may take 5 years or so to calcify a plaque. It doesn't show, however, non-calcified plaque. So a lot of folks maybe haven't been explained that it's the soft, non-calcified plaque that is vulnerable to rupture that promotes potentially a heart attack or a stroke, because when you rupture a plaque, a blood clot forms on top of that, leading to heart attack and stroke. So if, for example, I see a person has insulin resistance and high cholesterol, or what I call dyslipidemia, and I wish that they could take medication to lower their risk of vascular disease, in addition, of course, to proper diet, weight loss, exercise, the low-hanging fruit, but they're not interested so far in taking the next step, showing them that they have calcified plaque may encourage them, because it's going to change from an abstract comment that I made that your cholesterol's high to, I can see it. This is real. I see the picture. So in that vein, it's helpful. But in order to see the soft plaque, you have to do the CT angiogram, which has more radiation. It requires an IV contrast load. And it's more expensive, maybe $2,000.
Yeah.
But that is the better test.
Yeah, I found them informative for people on both ends, both to put people's mind at ease where maybe they're not having bad outcomes yet. So they've had high cholesterol for a long time, but it's not necessarily adding up to some of the accumulation within the artery walls. Going either way with those two tests. But also, I think, like you said, to really raise people's awareness, if they do have a calcium score that isn't 0, understand that there is calcification, which means that there is soft plaque, right? And I think that's the important thing. It's a progression from being soft plaque into a calcification. And as we start to see blood vessels narrowing, we're really starving that tissue of both oxygen and nutrients, which is what's going to lead to the decline in that tissue.
That's correct. So I try to divide it into two parts for people. I'll say this soft plaque is vulnerable to rupture, and that's what causes heart attack and stroke. Whereas you get a really older person with heavily calcified arteries, that's more likely to cause narrowing of the interior of the artery, starving that organ of its
Yeah.
blood flow, rather than having plaques rupture because that calcium stabilizes the plaque.
Right.
You know, atheromatous plaque in the artery is part of aging. Not everybody needs to take medication. So it's a discussion.
Yeah.
Hopefully, it's a discussion that you have with a young patient so that
Yeah.
they don't grow older with serious vascular disease. But, I tend to be more persuading people to take medication when they have high risk, like if they're insulin resistant or type 2 diabetes, smoking, high blood pressure.
One of the things that was a real, like, almost slap in the face moment for me was a conversation that you and I had where it was a really simple statement, but you just said, listen, what's happening in the heart is happening in the brain. You think of these as two separate systems. Everyone sort of talks about the brain and the body, like the brain is somehow different. But you described it to me so well in that we have pretty big blood vessels around the heart.
Yes.
And so they start to get calcified. They start to get plaques and they narrow and that takes a while. But the majority of the vessels in your brain are about the size of the tip of your pen, the microvessels.
Yes, like
And
a
so you
little
get
spider
much
web.
more blockage. Right. And so that for me, and that being a huge impact in causing of dementia, setting up an energy crisis in your brain, that was a really important point for me that just blew me away.
And not only that, of course, you have small arteries feeding the kidneys, feeding the penis. And so vascular disease
Yeah.
in the penis is a cause of erectile dysfunction. Those small
Yeah.
vessels close easily.
Yeah.
The arteries that feed the nerves in your lower extremities, if they are occluded, the hungry nerve tissue in your lower extremities is going to suffer. And that's one possible cause of neuropathy.
Yeah. Yeah. And I think, that's something that, like, with both diabetes and with coronary artery disease or vascular disease, we should call it, I don't think we've historically linked that to the brain. I think, there was so much emphasis on these proteins in the brain that we didn't think about it just in terms of we're cutting off blood supplies to entire sections of the brain here. And so, like, that brain fog that starts up, we start that gradual decline in our cognitive capacities.
Yes. So, I believe that vascular disease, by occluding the arteries that feed brain tissue, causes neurodegeneration and inflammation.
Mm-hmm.
I think that these proteins in the brain, like p-tau and beta amyloid, arise because of chronic neuroinflammation.
Yeah.
I don't know that they're a direct cause. I think that's just being worked out still. I always say healthy body, healthy brain.
Yeah.
Take care of
Yeah.
that body and you're taking care of your brain as well.
And I actually think that maybe a more effective way to convince men about this is to really emphasize the point about the penis.
Yeah.
It's so true. I actually read somewhere that it's actually erectile dysfunction is actually one of the sort of canary in the coal mine, the warning signs of future heart attack, like within the next 3 years, I think it said.
That's true. Some men, because they know they can get Viagra or Cialis, think, oh, I'll just take a pill. But I will tell them that there are plenty of men in my practice who are elderly who have gotten to the point where even those medications aren't so helpful anymore.
Right.
And then, we can try some other things, but you got to keep those vessels as healthy as you can.
Right. So we've got our new marketing messaging for cardiovascular vascular disease. So this is fascinating. And I think another area that I don't think we see a ton, particularly in younger people, is hormonal health. Things like hormonal and thyroid health. I know that's something that we looked at with my panel and Michelle's. Talk us through what we might see on a hormone panel.
Hormone panel for men, women?
Yeah, we just talk through both. We can talk about them separately.
So I do a lot of hormone supplementation for both men and women. And, whether or not I would recommend supplementation, it's a discussion. Not everybody needs it as they're aging. What I
And can I
look at,
just interrupt a second there? When you say supplementation, we're not talking about like going into, the supplement store and
herbal
buying some
products.
shelf.
Yeah.
We're talking about like HRT, like hormone replacement therapy here, right?
Yes. I'm talking about
Right.
supplemental hormone therapy.
Yeah,
Thank you for
yeah,
that.
yeah.
When I order a testosterone panel, for example, I use the more accurate mass spectrometry.
Mm,
And well, that's easily ordered at Quest Diagnostics, for example. That's the one I use. And it has the abbreviation MS. I will look for a total testosterone, which is just looking at, for men, how much testosterone are your testicles producing and secreting.
hmm
Women may make testosterone in both the ovaries and the adrenal glands. I look at free testosterone and bioavailable testosterone.
hmm
This can be a little tricky when you're looking at the report because for some reason, these are listed in different units of measure. For
Oh,
example,
wow.
total testosterone is expressed in nanograms per deciliter, whereas the free testosterone is expressed in picograms per ml. So when I'm talking to people, I will often adjust the free testosterone to nanograms per deciliter to keep everything consistent by
hmm
moving the decimal place one to the left. For example, if your free testosterone is 61 picograms per ml, I will say it's 6.1 nanograms per deciliter.
Right.
So you can see how that relays to the total testosterone.
Yeah. And explain that to me then. What's the difference? You mentioned 3 terms: total, which you said was just the total amount being produced. You said free and bioavailable. What's the difference?
So as I said, the total testosterone is what your organs produce. So testosterone can exist by itself, free floating in the blood. That's called free testosterone. That is what is available to your cells. And so when testosterone is taken up by the receptor, it's quickly converted to DHT, which is about 10 times more potent. And then that goes to the nucleus where it switches on genes involved in masculinization. So testosterone can also be bound to a protein called sex hormone binding globulin,
hmm
SHBG. When testosterone is bonded to sex hormone binding globulin, it is not available to the cells.
hmm
A young woman who has lots of estrogen production is going to have a very high sex hormone binding globulin level. SHBG is produced in the liver and estrogen ramps up the production. So a younger woman is going to tend to have a lower free testosterone level for that reason, because a lot of that testosterone is bound to sex hormone binding globulin. Free testosterone is usually about 1 to 3% of the total.
hmm
So what is bioavailable testosterone? For me, that's the most important. So bioavailable is a combination of free testosterone or weakly bound to a blood protein made in the liver called albumin. So albumin can bind to testosterone and unbind, bind and unbind. So bioavailable is the free testosterone plus weakly bound to albumin. We think that bioavailable testosterone is what is available to your tissues.
And does that appear on the report? Would that be under free testosterone, or is that something separate?
So my report says testosterone total. It will give you a sex hormone binding globulin level, an albumin level, a free testosterone level, and a bioavailable testosterone. So
Okay.
it gives you the full report. That's what I order. I don't
Yeah.
like ordering the total testosterone only. That's like ordering a total cholesterol, but nothing else in the lipid panel. You're
Yeah.
getting a little corner of the result.
Yeah. And you mentioned there that this is a hormone that is produced within women's bodies. One of the challenges that we've had with Michelle's care over the years is that it is widely recognized as a male hormone. And there have been massive regulations around women's bodies with regard to testosterone, and a lack of really awareness that women naturally have this within their body, and it plays a critically important role within a woman's body. So I think it's really important to sort of raise awareness there that women should know their testosterone levels and realize that it is important.
Agreed. I supplement many postmenopausal women with testosterone. Women have maybe 1/10 of the testosterone that men do. So I'm going to supplement that hormone at a much smaller dose.
Yeah.
I'll usually give a transdermal cream. I'll start with 2.5 milligram. I know that's very conservative, but I don't want to overdo it and then have to walk back the dose.
Yeah.
You know, testosterone can increase energy, maybe mood, certainly motivation, libido, improve bone density, and improve muscle bulk and strength.
Mm-hmm.
Obviously, it's not going to do that unless you're going to the gym and taking your creatine as well and your protein, but it certainly can help. And especially after 60 years old, I worry about sarcopenia, the wasting of the body with age. And testosterone helps to blunt that to some extent.
Yeah. Yeah. I think just the awareness that there are testosterone receptors in every cell in the body, you know, the actions that it plays in the brain and throughout the system, it sort of gets thrown into this libido category and sort of, I don't know, almost dismissed as unimportant because it's like, well, so you just don't have libido, it's fine. But I think that the wider health impacts of having physiologically normal testosterone levels, and we've just seen this with Michelle. She had hers measured a long time ago, and because she went through a hysterectomy, and it was literally at 0, and got supplemental testosterone, felt better, energy, mood, everything elevated. Then we moved up to Canada, and it's very, very hard to get. And so she really wasn't treated with it there. Got back on, everything improved, felt great. And then because she missed, there was supply chain issues and then was without testosterone for a month. The crash in her energy, the crash in her mood, mental health was really profound being without that one hormone, which really, again, is just lumped into sort of this libido category. But every aspect of Michelle's health was impacted.
Yeah, that's easy to believe.
Yeah.
I have a businesswoman who travels quite a bit. She's got a busy life. And I put her on a bit of testosterone. And she said she feels great. She rebounds from her trips with better energy. Her husband has noticed her energy. She just feels better overall. Just that sense of well-being has improved.
Yeah. Yeah, we talked with Dr. Kelly Casperson, who's a female hormone expert on the show, again, very early on. It was episode 10. But she said the thing she hears the most is just now, like she classifies it as a condition. I don't feel like myself, right?
Yeah.
That's the condition. It's not a specific thing. It's just this overall, I'm not feeling like myself. And so as we keep going here, we're already past the hour. What are some of the things that people should pay attention to with regards to things like liver health and kidneys, and just thinking about things like fatigue and mood and stuff that people would come and see you for that you might get some clues within their blood work?
Well, one thing I always order is an iron panel. I was talking to a physician recently who was taking care of one of my patients in the hospital. And she said, I didn't order an iron panel because there was no anemia. I can't believe a physician is telling me this. When you have iron deficiency, you have to cross a threshold before you develop anemia. So you can be, in other words, iron deficient without having anemia, similarly to the way you can have insulin resistance, but still a normal fasting blood glucose.
Yeah.
You have to cross a threshold. Your mitochondria, which do many things in the cell, but they're well known for being a power plant for the cell by generating ATP, rely on iron to generate that ATP. People who have iron deficiency often feel quite fatigued. And when I give an iron infusion, they feel amazing. Within a couple of days, their energy just picks up. So also in about 1 to 4 to 500 Caucasian people, there is a mutation called HFE, which causes you to overabsorb iron from the gut in an unregulated sense. It can build up in your organs and including your liver and cause fatigue as well. So I'm looking to make sure that the ferritin, which is my measurement of iron storage, is neither low nor high. So that's one. I do thyroid studies. I do a full thyroid panel, which includes TSH. That's the hormone from the pituitary that tells the thyroid gland to get busy and make thyroid hormone, which comes out of the gate as T4 and gets converted to T3 by your tissues. So I do the full panel. And these days, I'm also screening for the most common cause of hypothyroidism called Hashimoto's thyroiditis. More common in women and families, but men get it too. I do a thyroid antibody screen. So if you have anti-thyroid antibodies, you have Hashimoto's thyroiditis, and it's going to be inevitable that over the years, your thyroid gland may burn out, leading to fatigue. Other lab tests to look into fatigue would be a whole host of things, from looking at your blood cells to rule out anemia, looking at your kidney function. People who have poorly functioning kidneys feel fatigued. Abnormal liver test, which the standard liver test come in a comprehensive metabolic panel, a CMP, which is done in virtually all physicals.
Yeah. I was speaking to someone today who they were struggling with diverticulitis. And as a part of the ultrasound they got to diagnose this, were informed they had fatty liver. In follow-up, had some blood work done. And the doctor was like, well, you've got fatty liver, but your blood work's great. Don't worry about it.
It's another one that drives me crazy.
Me too, because that didn't happen on its own in isolation. It can't have been great. This is one of those outcome measures that is the result of an extended period of accumulating ill health.
So insulin resistance causes you to overproduce fat molecules and also to not burn them. So the net is that you accumulate fat in your organs. And so it's a spectrum between fatty liver, also called hepatic steatosis, to an inflamed liver, a steatohepatitis, to then, if it goes on long enough and the inflammation is aggressive enough, to liver fibrosis. It's thought that in the near future, fatty liver progressing to more serious inflammation and fibrosis may become the number one cause of cirrhosis in this country.
Wow. Yeah. So I think paying attention to stuff like this and the power of being proactive. And I think we're in a difficult moment in the US healthcare system right now, in the insurance-based model, where physicians have such a patient load placed upon them, so busy, that it really is almost becoming the responsibility of the patient to track and advocate for a lot of this stuff over time. Because I've seen people struggle to get appointments to even see their primary. And so missing follow-ups, not really having time to dig in like we might. It's really challenging environments. How can people advocate, first of all, for this deeper level of testing? How can people ensure that they're getting the right testing? And I think, how can people pay attention over time a little better to that longitudinal data?
Well, some people are lucky and they have the means to come to physicians that don't take insurance, and they are allowed to have more time for a lengthy discussion, maybe an hour or 2 hours per extensive visit. Not everybody has that opportunity. But I think folks just have to do their reading and listening and do some self-education with reliable sources.
Yeah, I think so. And so what should I say to my doctor? Give me a script where because I'm not trying to offend my doc by asking for more than they might have prescribed. But what would you say going into the doctor? He's busy, she's busy, and they've got this patient load. They're ordering a pretty generic panel. Like, what should I say?
So I want to be healthy for the long term. These are the things I'd like to screen for, just to make sure that if there's any problems, I can take action. Are you willing to order these tests for me? And these days, people can order their own test. But an insurance may have a problem with that because the doctor hasn't ordered them. So it can be tricky or not. But you're going to get different responses from different practitioners. Some are going to be flexible and open-minded and say, let's do it. And others may say, that's nothing. That's not important. And I don't have the time or don't want to be stuck diving into these results that maybe I'm not comfortable with. Maybe I don't have the knowledge basis for it. Or maybe I just frankly don't accept that this is an important test to do. You're just going to get different responses. And I think that every physician attracts a different kind of a patient. typically my
Mhm.
patients want to dive in deep, and I'm
Yeah.
happy to do that.
I think that there's a couple of important points there, and there is a lot of commercially available blood testing that can be done now, and I think it's important to do this in partnership with your physician. I think involving physicians and registered dietitians in this process is super important, because you don't know where these guidelines are coming from with these independent commercial companies. You don't know who's creating the guidelines. Mostly I've found that they are supplement companies. They're just trying to sell you something.
Very persuasively.
Yeah, exactly. And so I think finding the right doctor who will enter into this as a partnership, into this process with you, I think it's just really important that we don't lose sight of the importance of our MD and our RD in this process.
Yeah, I think in general, it is best to go over the results or order the results with a professional provider. I'll give you an example. Just this week, I saw a new patient who she's been feeling malaise, fatigue for months now, kind of abstract symptoms, just doesn't feel good.
Mm-hmm.
And she got together with some rep for Quest and ordered an autoimmunity profile. You know, there was a very weakly positive result, which is nothing.
Yeah.
It's nothing. And, I told her this is not likely to be anything to worry
Right.
about. And you don't have any other signs or symptoms of these particular diseases, which are on this panel. That's the danger of ordering tests where there's not a
Yeah.
really good reason. If your pre-test probability of having that condition is low, your false positive rate is going to rise.
Right. And again, you have no context, right? If you're a layman and you order this autoimmune panel and you get a result that says that this is positive, maybe any of these factors that we've talked about today could have skewed that result, but you don't have any of that context as a non-trained practitioner. And so I think it's so important that we're having these conversations with our medical providers. I like to track my blood work. I use Inside Tracker, but I know Quest have options to do this. I like to have my blood work and see it over time because I've moved so much.
Mm-hmm.
But it's always going to be reviewed, and the interventions are always going to be with my physician, because I'm not just going to follow Inside Tracker's AI generated recommendation for me. They don't know anything else about me. And so, just to emphasize the importance there of, be aware, track your stuff, but really do this with a care team.
Sure. You tracking your results means you're in it. You're in the game. You're aware of and a partnership with your provider.
Yeah. Yeah, exactly. So Dennis, as we wrap up here, we do 3 takeaways every episode. What would be your 3 things that people can take away from today's conversation in how they can better interface with their own health, with their physician, with their blood work?
Well, one is where we started. Prepare yourself well for your blood draws so that we don't get skewed results and get down the wrong path. Order the tests that can predict trouble down the road so that you can take steps to be healthy as you go along with age. And 3, if you're lucky enough to have the time to do so, get into those discussions with your provider. Be prepared with questions.
Mm-hmm.
Rather than just, hearing something and hitting the door. Be involved with your health. I always tell people, because sometimes we forget, we have this one beautiful life, this one chance. And, if you're lucky enough and you take care of your body, you can be in good shape and independent for many years to come. But if you turn your head the other way and you ignore these things and you have an unhealthy and limiting older life, that's really unfortunate the way I see it.
Yeah. I just couldn't agree more there. I think, again, this data that we gather just drives our decision making. And if we're involved and we're paying attention and we're working with our doc, we can really extend the quality of our life. We have really great years for a long time. We don't have to accept an inevitable decline into ill health.
Right. I hear people sometimes when they have bad habits, they'll say, if I die, I die. And they envision they're just going to drop in 1 second. Well, that
Yeah.
rarely happens. Usually what happens instead is the poor health kicks in, and it's this long, slow, lumbering process of ill health and feeling poor and losing your independence and ability to do enjoyable things.
Yeah. What an important point that is. That's such a great way to frame it. Again, I haven't heard it described like that, but it isn't the case that you're just going to be here 1 minute and gone the next. That nobody wants part of that decline.
No.
So, Dennis, where can people find you?
I'm in Santa Barbara, 1292 Coast Village Road in Santa Barbara. Dennis Hughes, MD at yahoo.com and DennisHughesMD.com for the business website.
And for people who might be in the area lucky enough to work with you in your practice, do you also work with people remotely? Can you work outside of California?
I do. I work with people occasionally who are on the East Coast or in the San Francisco Bay Area for things that don't require a physical exam. Obviously, I can't do that through the screen, but I can do some other things. I can review labs and discuss anything else.
Yeah. Well, I for one would recommend anybody with the means to be able to do that, to get in touch with Dennis and
thanks for the plug.
Participate in his practice, because it the in-depth, the insight that you give people, really, I think it's life-changing for people. So really appreciate your work and appreciate your time today.
I enjoy it. Thanks for having me.
What an amazing conversation with Dr. Dennis Hughes. Here are the 3 key things that you can take away from today's episode. Number 1, prepare properly before your blood draw. Start hydrating the day before. Stop biotin-containing supplements a week out. And keep your normal medications and morning routine. What you do before the draw shapes what the results will actually tell your doctor. Number 2, ask for the tests that see trouble coming. Fasting insulin, ApoB, cystatin C, a full iron panel, and a complete thyroid panel are all accessible, often inexpensive, and can reveal what standard labs miss by years. The thing is, you may have to ask for them. Number 3, be an active participant in your healthcare. Track your results over time. Come to appointments with questions and build a real partnership with your provider. The gap between a long, high-quality life and a slow decline often comes down to how engaged you are right now. If this episode resonated with you, the best way to support the show is to follow us wherever you listen to your podcasts and leave a rating or a review. It makes a real difference in helping us reach more people who could benefit from these conversations. You can stay connected with us on Instagram, LinkedIn, and YouTube at Vitality Collective Performance, where we share additional insights, behind-the-scenes content, and updates on upcoming episodes. The information shared in this episode is for educational purposes only and is not intended as medical advice. Always consult a qualified healthcare professional before making any changes to your training, recovery, or health practices. Thanks for being here, and we'll see you next time.